So our next speaker is Dr. Rajesh FOGLA. Again, a person I don't think any surgeon really needs to have, or he needs an introduction. He's a very, very renowned corneal surgeon, corneal refractive person. And today he's going to take us through cataract surgeries, his learnings while dealing with ocular surface disorders and cataract surgeries.
Good morning, everybody. And I think congratulations to the people who made it. Because otherwise the speakers were outnumbering the people in the audience. But fortunately now we have, I think it's still outnumbered, right? But you are the lucky guys who get to hear all the pearls about managing. So the topic Shweta has given me on navigating cataract surgery in eyes with ocular surface disease. And when we look at cataract surgery, it's one of the most frequently performed ophthalmic procedure worldwide. And ocular surface disease can have an impact on the outcome of cataract surgery, especially in this era when we use all the premium lenses where patients desire the perfect visual outcome. And studies have shown that in the elderly population, almost 60% of the patients that present for cataract surgery can have some form of ocular surface disease. So it's important that we take this into consideration for the pre-op, intra-op, and post-op, post-operative duration regarding cataract surgery for optimizing the outcome. Now you can have an actual dry eye situation where you have deficiency of tears. So when you stain the surface, you can see surface staining, reduced Schirmer's, and the lower tier meniscus would be reduced height. It can be seen in almost about 30% of the patients. But other than that, more commonly what you would see is some form of meibomian gland dysfunction or blepharitis, which is quite common in the elderly population. You may see some chronic conjunctivitis as well, especially what we see is people coming in the equatorial belt. You can see trachoma, which can present with conjunctival changes. And this can often lead to some sort of limbal deficiency, partial, and or you look out for conjunctival scarring, which may be associated with conditions like ocular cicatricial pemphigoid. Now remember that whenever you have an ocular surface disease, you can have poor tear film stability, which can lead to fluctuation in vision. Hence the importance of assessing and managing this. So in the pre-op evaluation, just don't look at the cataract and jump in and say we need to do a cataract with a multifocal lens, but also assess the ocular surface. I would say look at the lids, look at whether there is ectropion, whether the lower lid is lax, there is conjunctivocalysis, or if there is any associated chronic meibomitis. So it's important to look for tear film stability. And the simple thing that you can do is put a fluorescein and just ask the patient to blink and look for the tear film stability. And the second thing is look for any surface staining on the cornea or the conjunctiva. Yeah, if you can have meibography, you can assess the meibomian glands and see whether there is extensive dropout. And before you proceed with the surgery, I think it's important that you optimize the surface. This is important not only from the surgery and the post-op outcome, but also in the pre-op calculation of the IOL power. Remember that if you have a surface that's not very good, then you can have irregular readings. Sometimes you may have astigmatic measurements, like it may show astigmatism when there is no astigmatism at all, and you may end up putting a toric lens and have an undesirable outcome. So in terms of how do you optimize the surface? Well, you use lubricants, and nowadays you have a lot of preservative-free tears. So ideally you should use that. If there is significant inflammation, you can consider using low-dose steroids, softer steroids, or cyclosporin. Consider lid hygiene, warm compress. And in severe cases, sometimes you might even put a temporary punctal plug to allow the optimization of the tear film. During surgery, yes, choice of anesthesia is important. If you have a fragile surface and if you repeatedly put topical anesthetic on the cornea, and the cornea is not very healthy, you can end up with the cornea developing epithelial defect, even intra-op, and that can post-op sometimes be delayed epithelial healing. So with the advent of intracameral medications, you can consider either giving a subtenance or you can just give a intracameral anesthetic as well. use topically. Even in the post-op, think of using non-preserved medication. If you want to use a steroid antibiotic, I like to use a combination, like you have the Vigadexa, which is available from Alcon, which is again preservative-free. So that's something nice for patient. The number of drops that you apply on the surface can be minimized. During surgery, you can put some methyl cellulose on the corneal surface, so the nurse doesn't have to keep irrigating the surface frequently, because the more you irrigate the surface, you can hydrate and the epithelium can become loose. So protect the surface with a layer of viscoelastic, which improves your visualization, and you can do that. And also remember, in these kind of eyes, you don't want too much of inflammation. Try to do a phacoemulsification using lower parameters. And yes, flux can be considered, where you can get the rhexis and the fragmentation done, so the overall use of phacoemulsification can be minimized. For visualization, if you are not very clear, then you can use the trypan blue for conjunctival staining. Remember, sometimes you'll have peripheral vascularization as well. When you make your main incision site ports, you can have more bleeding, so you need to watch out for that. So I like to put that HPMC layer on the surface, so that kind of ensures that the blood does not come into the central cornea, does not obstruct your visual field. Use dispersive OVD, and if you don't have a surface that's really good, don't venture out into putting premium lenses. Maybe in those kind of patients, just to select the monofocal plus lens, and explain the patient, look for monovision if somebody wants to get, unaided good vision for distance and near. Because if you go ahead and put a multifocal, trifocal in this, because of this surface problem and the tear film problem, they will keep coming back to you, and they will never be happy or satisfied with the outcome of the surgery. Post-operatively, so you continue with the medications, whatever you treat the surface with in the pre-op. Avoid topical NSAID post-op, because again, if you don't have a healthy epithelium or the surface is not great, you can end up with epithelial toxicity with the use of NSAID. And you can still continue with the punctal occlusion. What I like to do is use chromic catgut 20. You can cut small fragments of it and you can put it in the punctum. That stays for about a week or two, and that buys you optimal time, so you don't have to aggressively keep lubricating the surface post-op, and the patient would be happy with that. So basically, I think the key factor is there is no major variation in the surgical technique of cataract surgery. If you have OST, the main thing is the recognition. Like, don't just focus on the cataract, also spend time to look at the surface. And if you feel that somebody has problem with the surface of the tear film, treat that, optimize the surface, then go ahead with the cataract surgery, because you can get better visual outcome. And remember that you can counsel the patients accordingly, make them aware that there is a ocular surface problem, and that will require treatment post-op. So if you have discussed or spoken to the patient prior to the surgery, the patient will be more comfortable, rather than you just springing on the patient post-op and saying, oh no, you have a surface problem, that's why the vision is not good, but you have never discussed this pre-op. So the patient feels that it is something to do with the surgery, and they keep going around, ask various other for second opinion, trying to figure out why this has happened. And sometimes we see patients are given a cocktail of medications. They are put on a lot of lubricant, gels and everything, but that doesn't, because that is not addressing the primary problem. That is only trying to be palliative. So I think if you don't have the clue as to why the dry eye is or the surface problem is happening, and if you don't treat that, no matter how much of lubricants you use, the patient's problem will never be solved. So assess pre-op, intra-op, take care to protect the surface, continue with the treatment post-op. I think with this, you can achieve reasonably good success in the doing cataract surgery in these eyes. So it requires a comprehensive approach. Early diagnosis, intervention, and tailored treatment enhances the success. And I think more and more preservative-free medications we are fortunate that we do have a range of preservative-free medications. So use them, but I think that we should not go overboard, because if there is no infection, there is no need to use topical antibiotics for a prolonged period of time and in great frequency. Sometimes using it 2 hourly or using it for the entire duration of steroids is not mandatory. Just use it for the first 5 days, I think, till the epithelial healing is complete over the incision, and I think then you can stop it. And so I think this is very important to consider when you're planning the post-operative treatment. Don't use the same post-operative treatment for all your cataract patients. And in future, maybe more diagnostic devices to make it easier for people to screen for ocular surface disease. That would be great. ASCRS has a very nice flow chart and a treatment algorithm for dealing with OST and cataract surgery. I think You can, it's freely available. You can go and download that flowchart. That gives you a algorithm as to, how you proceed if you have a patient, both in terms of diagnosis and when and what to intervene, and what do you do in case there is a problem in choosing the lens and the IOL power calculation. Thank you. Thank you for a patient hearing.
Thank you so much. I think one of the most important factors that you've highlighted in the talk is to identify the cause that we have the OSD for and treat it. Otherwise, just using lubricants does not take care of the OSD.
Yeah, so we see patients, sometimes somebody has a conjunctivocalysis, and that will keep irritating the eye, and if you don't see that and you try to address that, the patient will never be, he will continue to have the symptoms. Or if somebody has, some superior limbic keratoconjunctivitis, which we have missed out, the patient is a thyroid patient, and then you don't avert the lid and take a look for it, or somebody has concretions in the conjunctiva, and these are things that will keep making and what happens is, they may have had the problem pre-op, but then it was not symptomatic. Once you do surgery and you're manipulating the surface, putting medications, then they become symptomatic. And that is attributed to the cataract surgery, which is the intervention that you have done. So you cannot go back and say, oh, these concretions have been there before. But patient will say, I was never symptomatic. Maybe the patient was subclinical at that point of time and became clinical later on. So that's why pre-op, maybe in elderly patients, it always makes sense just to avert the lid, take a look at it. Sometimes chronic trachoma, you can have fibrosis, scarring in the upper tarsus. So these are things. Surface staining is very important, because a lot of these clues you can see, because if there is any pathology in the underside of the lid, it will show up as corneal staining. But you need time to just do that stain and take a look.
Correct. Thank you so much, Dr. FOGLA. Any questions from the audience?
Any other points you want to add, you can always add. Well, you would like to make the incision in the least where the cornea looks almost normal. You need to watch out for, sometimes in elderly patients also you can have variation in the corneal thickness. There may be peripheral guttering or, furrow degeneration. So if you are used to doing your standard surgery and you go ahead, you may end up with problem. But if you feel cornea is quite involved, and if the conjunctiva is normal, I will open the conjunctiva, I'll make a scleral incision, because scleral incisions are more robust in terms of they withstand the manipulation better. And at the end of the surgery, you can close the conjunctiva so your incision gets covered with that.
It was very nice to hear that, you choose a right IOL, intraocular lens, for those patients. Many a times, these patients who have undergone premium IOLs come back for opinions just because that they have a fluctuation in the vision, because the surface is not stable. So maybe for mild surface diseases, it is okay, like you treat the surface and then decide for your premium IOLs. But for moderate surface disease, probably it would be a good choice to have monofocal IOL rather than premium IOLs.
See, the problem is not that. Patients nowadays Google,
Absolutely.
or they have friends who have undergone cataract surgery. And if the neighbor says, oh, I had a surgery, I got a trifocal lens, and the patient comes and demands that, I want a surgery, but I want this.
Yes.
I want this lens. Then what happens is the surgeon is under pressure. He doesn't want to lose the patient. And he says, okay, if you want this lens, I will do it. And later on, when the patient is symptomatic, you try to put the blame on the patient, saying that, oh, you only wanted this lens, I put it. But patient does not understand. So it is your job to make the patient aware of what the problems are and how it can impact his visual recovery.
Yes,
So
absolutely.
this is very important, because people go on ChatGPT or they Google and they find out what, they come and say, oh, I want a EDOF lens, I want a trifocal lens. These are good, but for most of the patients, I tell them, oh, if I had to have a surgery, maybe I'll just have a monofocal plus. I wouldn't have, because I want to preserve my contrast. And it takes a little bit of chair time to explain to the patient or the patient's family. And I think that way you can ensure that post-op you don't spend up too much of chair time dealing with this patient. They might even scare away some of your patients while they're waiting outside, because they keep waiting and they will tell you, oh, I had surgery, I'm not happy. And your next prospective patient will say, oh, better go somewhere else.
True. Thank you.